welcome back to Ironwood Cancer Insights. My name is Delaney. Today I have radiation oncologist Dr. Sam Sun here with us. We're going to be going over some of the fundamentals of cancer and kind of get down into what exactly cancer is. So to get started, can you explain to us exactly what cancer is?
Yeah. So cancer is a variety of diseases like lung cancer, breast cancer, defined by two traits. One is uncontrolled growth locally. So if you have a tumor, a mass, and it grows over months or years and can cause damage to skin, can press on blood vessels and involve nerves and cause pain, that sort of local destruction defines cancer. And then most cancers also can spread to other places in the body. So for example, lung cancer can spread to the bone or to the liver and cause additional problems outside of the organ where the cancer originated.
And how does cancer develop?
Yeah, so we're both on the younger side. I don't think cancer is necessarily inevitable. It's the second most common cause of death in the U.S., right behind heart disease, and it does get much more common as you get older. Although we are seeing kind of an uptick in younger adults with cancer. I would say that most cancers are caused by environmental exposures over the years. So the most common things that we're exposed to that have a strong likelihood of causing cancers, those would be things like smoking, alcohol, dietary factors, like if you eat a lot of smoked fish or red meats, that can increase your risk of different GI cancers. Obviously here in Arizona, we get a lot of sunlight, and if you get enough sunlight, then inevitably you'll have some sort of skin cancer as you get older. So those are all things that can cause sort of common cancers, but our risk of cancers does go up as we get older, and sometimes there's not kind of a clear cause of a cancer when you end up going to your doctor and finding something out.
What role do genetics play when it comes to cancer risks?
Yeah, so genetics is definitely a big part of what contributes to our cancer risk. I would put genetics into kind of two categories. One is there's sort of like well-defined genetic syndromes. You can have families where it seems like everyone's developing cancer, everyone's developed cancer in the last couple generations. I would say those syndromes are kind of like if you have like a dog breed, you can label like a pure breed. This is like a golden retriever, or this is like a Pomeranian. And there's something similar for cancer genetic syndrome. So the BRCA1 and 2 genes, for example, have been very well characterized, and they're a set of mutations that strongly predispose to breast cancer and ovarian cancer. Similarly for colon cancers, Lynch syndrome, or mutations in I believe the FAP gene, they can increase the risk of colorectal cancers and necessitate more screening, and potentially some prophylactic procedures as well. I would group the second category of genetic syndromes into, they're sort of less well characterized, but for example, you might have a grandparent who developed cancer. Your risk is probably higher than somebody who doesn't have any family history, but you might not be able to find a specific gene or kind of a specific inherited mutation that increases your cancer risk. But your risk is probably a little bit higher. Instead of 1 in 10 during your lifetime, it might be 1 in 5 in your lifetime. So for example, in those cases, I would just say being aware of your family history and being sure that you get the appropriate cancer screening.
And what are the different stages of cancer, and what do they exactly mean?
Yeah. So I would say that cancers range from stage 0, the earliest stage, to stage 4. Stage 0 is a little bit different from cancer to cancer, but it generally means that the cells, if you look at a piece of the tumor, the cancer under the microscope, they kind of look aggressive. They look wonky. They don't quite look like, for example, normal breast tissue or normal colon tissue. Instead, they look like cancer cells. But if you look at kind of the local architecture, and in particular, you can find the basement membrane or the wrapper for the tissue. Those cells haven't spilled out of that wrapper, so it's still kind of local, and it doesn't really have any potential to spread. So stage 0 is good. Stage 1 is also good because even though it's broken out of the wrapper for the tissue and has some potential to spread, it's still in the original organ. Stage 2 and 3 are various degrees of spreading locally. So, for example, to the lymph nodes, or if the cancer just grows large enough that it goes through the skin, that would be a stage 2 or 3 cancer. And then a stage 4 cancer is the most advanced stage, and that's when the cancer is spread outside of the original organ into the bone or the liver or the brain or somewhere else in the body besides where the cancer originally came from.
And can the stages of cancer change over time or during treatment?
Yeah. I think the most common way that the stage of the cancer changes is we stage the patient fully when you come to us with the problem and we identify that you have cancer. Through treatment, hopefully we can get the cancer to just go away. And if you come to us, for example, with a stage 2 lung cancer, we cure it with radiation, or we cure it with surgery. It's gone, hopefully. And we can ascertain that with kind of imaging, with blood tests. And if it's gone, then you had a stage 2 lung cancer, and it doesn't go down to stage 1 or stage 0. It's just gone.
Okay.
And that's the case for sort of any cancer at a more advanced stage. If you're cured or if you're in remission, then we just refer to you as having had or having a stage 2, 3, or 4 cancer that's in remission.
Got it.
The cancer stage can kind of increase over time. So, for example, if you come to us with a early stage cancer, over the course of several years after initial treatment, the cancer ends up coming back in, for example, another part of the body. Then it would be stage 4 at that point. So I would say that the stage can potentially increase, but if treatment is successful, which we always hope it is, then the stage doesn't decrease. The stage just represents sort of the most advanced version of the cancer throughout your whole treatment history.
And what is metastatic cancer? How is that different, or is it different than the stages?
Yeah. So if you are with a family member, for example, and on their PET CT or their MRI, it says the word metastatic. It refers to one of two things. One is the cancer can spread to local lymph nodes, and that's called kind of a lymph node metastasis. That would only increase your stage to stage 2 or 3, depending on the cancer and the number of lymph nodes involved. And then we can also see that cancer spread to other locations distant to the organ where they started, and those are distant metastases. So when I hear someone say that they have metastatic cancer, I generally think that they have a more advanced cancer.
Can you explain to us a little bit the difference between a benign and a malignant tumor?
Yeah. Sort of going with the last topic. A malignant tumor is a tumor that has the ability to metastasize, or the ability to really cause problems through local growth. A benign tumor we sometimes see as well. Definitely more rare for us to see benign tumors, at least in radiation oncology. But if you come to see one of our breast surgeons, for example, you don't necessarily need to have a cancer diagnosis. You might just feel a lump in the breast, and they end up doing imaging or a biopsy, and they find that you have a number of other breast conditions that aren't cancer, and we would just call those benign, as in they're well behaving. They're not a real disease. It's just something to sort of know about. But benign is always good. Malignant, you don't have a malignant tumor, and you don't have malignant colleagues. And malignant is generally sort of a more aggressive type of condition that you're dealing with.
What are the differences between an aggressive cancer and a slow-moving cancer?
Yeah, so I'd say that aggressive cancers are, I think of those as ones that divide more quickly, grow more quickly, are more likely to spread to other parts of the body, respond poorly to treatment, and ultimately are more likely to kill you if you don't get treated. I think of this as, for example, many blood cancers are aggressive. Head and neck cancers, small cell lung cancer, pancreatic cancer, just cancers that are, they may be less common, but if you do develop them, then the risk of causing problems in your life is much higher. Slow growing cancers are ones where you don't necessarily need to start treatment in the next few weeks after you're diagnosed, but they're ones that should still be managed medically. So slow growing cancers are sort of more slow moving cancers. I would put many prostate cancers in that category. If, for example, you're a 70-year-old guy and your PSAs are creeping up from 3 to 4 to 5, and you go to your urologist, get a biopsy, you find you have a low or intermediate risk prostate cancer, then you really have some time to figure out the best treatment for you. And you don't necessarily need to kind of jump on the treatment with the first doctor you see. You can kind of do your reading, and you may have a few months to make a decision.
And as a radiation oncologist, how do you determine what treatment is necessary for the type and stage of cancer?
Yeah. So I would say that for 98% of patients that walk into our clinic, they're a type of patient, or they have a type of cancer, a stage of cancer that I've seen maybe dozens of times before, either during training or out in independent practice. So we have, I would say, different recipes that we use to put together a radiation treatment for patients. And then I would say that, your physicians at Ironwood, we're always reading and going to conferences and talking to each other, and learning about any updates or improvements to current treatments. And so if anything kind of it changes for certain cancer types, if there's new radiation treatments for kidney cancer or lung cancer, for example, I incorporate that into my practice as well. It's always better to come in as soon as you have a cancer diagnosis, and not wait too long for the cancer to grow or to spread. If you have a smaller cancer, it just increases the likelihood that we can cure your cancer, treat it effectively, and treat it effectively without just making you really sick. So as a radiation oncologist, I always like to see if my patients have earlier stage disease. It just makes it more likely that they can be treated effectively. But even if you have stage 4 or metastatic cancers, we can treat you with a variety of options. But sort of as the patient, the earlier you can come and see your doctor, the better.
All of our providers at Ironwood do subspecialize in different types of cancers. Can you explain to us a little bit why that is so important?
Yeah, so I think with cancers encompassing such a wide variety of conditions, I always feel better when I'm able to work with medical oncologists that subspecialize. When you're working with someone who just treats breast cancer, just treats lung cancer, for example, then they really understand the latest advances in treating that particular cancer type. We have a variety of clinical trials throughout our Ironwood centers, and we're able to enroll patients on those trials. So patients are able to get potentially life-saving medications before they're broadly available. And I would say other reasons would be there's a host of other physicians that we work with. So for example, the GI medical oncologist who works with me, he knows all of the gastroenterologists, the folks who would perform your colonoscopies and endoscopies, the hospitalists in the area that work with GI cancer patients, the GI surgeons, and he's able to sort of coordinate care in kind of a integrated manner for you. And when you work with folks that sort of see everything and they're just community generalists, that might be good in sort of a small town where you just don't have the resources to have oncologists specializing in specific cancer types. But in a place like Phoenix, it can be really helpful to have that subspecialization, just to have that coordination of care and depth of knowledge to really have the best outcomes and the best result from your cancer treatment.
Dr. Sun, you're pretty new to our facility here at Ironwood Cancer and Research Centers. Is there anything that you've experienced or anything that you want to share that you've learned so far?
Yeah, so I've been here for about a year, and our Goodyear site has been open for about a year. One thing I have noticed practicing in Phoenix is that a lot of my patients with early stage breast cancer, they're seeing their plastic surgeon before they see me. So I feel like it's a little bit of the tail wagging the dog. Maybe it's just the last month, but I've had maybe 5 patients with early stage breast cancer who could be getting a lumpectomy, a much smaller surgery. Instead, their plastic surgeon talks them into a mastectomy and breast reconstruction, and in theory, it's not a bad option for patients, but especially within the last 15 years, there's a wealth of data showing that in patients with early stage breast cancer, breast conservation, a lumpectomy plus post-op radiation in terms of survival, freedom from ever having to deal with a breast cancer diagnosis again, quality of life, and overall happiness with your treatment compared to mastectomies and possibly reconstruction afterwards. I'm not exactly sure the reason why people are opting for mastectomies. They tell me that maybe a family member, a coworker wanted to have mastectomies. It might be sort of the Angelina Jolie effect. Maybe 10 or 15 years ago, Angelina Jolie found that she had a gene, BRCA1, that increased her likelihood of having breast cancers in her lifetime. And for those patients, I think mastectomies is a reasonable option. But for the typical patient who doesn't have that particular genetic mutation, I really don't think mastectomies are a good treatment option at all. Yeah.
I have a question to go off of that. If I was, say, a patient who did have a diagnosis, what would you recommend? So instead of going to see a plastic surgeon, do you recommend coming to see a radiation oncologist to see all your options?
Yeah, I would just say that if you do have an early stage breast cancer, after we've done all the imaging, including an MRI, which is very sensitive for detecting disease, if you have a early stage breast cancer, then the first step is often surgery. If you have a more aggressive breast cancer that can still be early stage, HER2 positive or triple negative breast cancer, for example, then the first step would often be chemotherapy or immunotherapy or targeted therapy. In that case, you can have substantial reduction in the size of your breast cancer. We repeat a breast MRI after that initial treatment, and oftentimes the tumor can just be gone. In those cases, I just want patients to sort of know that even if the entire breast is removed with the mastectomy, it doesn't mean that the cancer can't come back, either underneath the skin or in the chest wall or somewhere else in the body. And the literature really shows that patients have a higher likelihood of having the cancer come back, and a higher likelihood of, in a minority of patients, a higher likelihood of potentially dying from the breast cancer if they opt for that kind of mastectomy and reconstruction approach. I think that really should be reserved for patients who have a family and genetic history of breast cancer. And for patients that are very young, for example, in their 20s, I think that's reasonable. And then for patients who have a very large breast cancer, where taking the whole breast out makes sense, I don't think reconstruction makes sense for those patients at all, because you might have something grow underneath your implant that you just wouldn't be able to detect on physical exam.
Thank you.
And the last thing I want to say is that radiation for breast cancer, especially early stage breast cancer, is much better now, especially in our hands. And patients have minimal side effects, if any. What I tell patients is that most of them will have no side effects that they can tell during radiation or afterwards. And we can't say that about surgery, because you're going to have pain. We can't say that about chemotherapy. Can't say that about any other breast cancer treatment, but you can say that about radiation. So I just want to sort of emphasize that the way that we do breast cancer radiation now, and really over the last 4 or 5 years or so, is really much better than it has been in the past. There's going to be minimal burning, in most cases, really no skin changes at all, no pain, and it's a much better, kind of easier treatment option for patients with early stage breast cancer than a more kind of aggressive surgical option.
So much, Dr. Sun, for joining me on this podcast today. If you have more questions or if you want to learn more, you can visit us at ironwoodcrc.com or call us at 480-821-2838. Thank you and take care.